Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Jennifer MacGregor. Ms. MacGregor is currently Vice President of Digital Patient and Provider Experience at Fraser Health, where she provides strategic leadership to areas of digital technology, virtual health, patient-provider experience, innovation, and research. Ms. MacGregor, Jennifer, welcome to the show.
Thank you very much. I'm very much looking forward to today.
As are we. We are so looking forward to having you on today. You've had such a fantastic career all over the world that blends technology and healthcare, impacting patient care and provider experience globally. You've been on almost all sides of the proverbial healthcare table, from consulting, leading teams at Allscripts, and now leading digital patient and provider experience at Fraser Health in British Columbia, Canada. I'm really curious to dig into your foundations to start. What got you into healthcare in the first place?
I have always been in healthcare and have always been in healthcare IT. My first job, I was 9 years old and I got paid a penny a page to enter healthcare billing codes into a batch system that would run at night. And quickly after that, by the time I was 12, 13, I was implementing billing and scheduling systems, and away I went. So I've always been in the business. Haven't done really anything else but healthcare, life science, and technology.
You know what's amazing? There are a lot of folks who start in healthcare and they want to leave, but it's too late. But you started early and said, oh, this is awesome.
I loved it. There's nothing more purpose-driven and more rewarding than this business.
Totally true. And after getting a penny per page, that's you racked up $1 million pretty quick and then saw your way forward. So I did notice from your background, following your degree, you went for an MBA, which actually included an international stint at Aarhus University in Denmark. And what motivated that decision, and how have you found working abroad? How has that impacted your career and maybe made you a better leader overall?
I always wanted to broaden my perspective and understand people and how they work and what's different, and other cultures and other geographies. And I always wanted to have an international lens and an international perspective from as far back as I can remember. And I love travel. I mean, who doesn't love to travel and to see the world? And so it was really important to me that my career included that international lens, and that I raised my hand at every opportunity that I had to go international. And so part of the MBA program, there was an opportunity to go to Europe for a portion and go to Aarhus. And I raised my hand right away, and it was an incredible experience, very rewarding. In that program, I was able to work with people from all over the world as part of the project team, really understand how people communicate differently, different backgrounds, different perspectives, that diversity, really early in my professional growth, which was, I think, really important. And I've been able to learn so much from different health systems and different organizations around the world since then. I bring a global perspective. In MBA speak, we used to say, act local, but think global. We used to say glocal back then. And I really do think about that often. It's globally, how could I create or think about something differently? What have I learned elsewhere? Can I bring that to either the organization or the particular problem or challenge they're facing now? How can I bring that to the table? And I think it's really important to have a global perspective.
What was your favorite country that you've traveled to?
Oh my gosh. I've been to so many places. I think it depends on from what perspective. I love Australia. Australia is absolutely one of the most incredible countries I've ever visited, stayed in, and worked in. Singapore also is very high on the list. An incredible country, an incredible way that they think about technology and how they introduce technology and how creative and innovative they are and how they bring technology forward, especially in healthcare, and the healthcare system is phenomenal. So every opportunity I had there was wonderful. I did enjoy my time in the Nordics from a schooling perspective, also very good. And of course, a big portion of my career has been in the US. Very different than the other countries that I worked in, very different health system, yet facing very similar challenges. But I would say if I had to choose, Australia and Singapore would probably top the list. Don't tell anybody.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You know, you and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. You know, that would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from, so you can find that evidence right away. That builds trust.
Oh, exactly. You know, being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Keel AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
You know, Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more.
I think my sense, having worked with providers in different countries, has typically been the way of delivering care and medicine overall is very, very similar, but the reimbursement model, the payment system dramatically changes parts of the healthcare system. Did you find that to be the case, or was there anything else besides reimbursement you found to really change how healthcare actually got delivered?
I think reimbursement and how it's structured as far as the responsibility of primary care versus acute care is different, or community and long-term care. It is structured differently in different countries. And so because of that, there are different rules and different ways to connect and share information, which is what, you know, I was really focused on. I think another key part is the scope of each discipline is different. So in different areas, you would have, you know, PAs, for example, that have a particular scope, RNs, LPNs, and, you know, phlebotomists, and who does what, when, where. And that makes a difference when you're implementing technology. So there are some differences there.
And I think probably unique to Canada is I think even in different provinces, we're seeing the scope of practice change as well. So you can't even say this is how we do it in Canada. You just say this is how we do it in BC, which is like mostly the same, but still could be different than what's going on in Ontario and whatnot.
Yeah. Yes, there are differences.
Awesome. So Jennifer, you were a senior executive at Allscripts in the EHR vendor space for over 15 years before finally transitioning just last year to lead digital health for the large health system of Fraser Health. I assume that presents a unique set of challenges and opportunities where you are currently as compared to the EHR vendor space. But I'm curious, how do those two environments compare? Like, what's similar, what's different?
So I think from a similarity perspective, and I'll begin there because there are fewer similarities than there are differences. But from a similarity perspective, I guess it would be passion and empathy. You know, in order to be in this business on either side of the table, you have to have an extreme passion for what we do because what we do matters, and a lot of empathy for those either we serve, and of course, we have many that we serve as far as our clinicians, our medical staff, our end users, our patients, our caregivers. So we have extreme empathy and a real passion for what we do. That's what drives you to work the hours we work, and it drives you to make the deliverables you make. And so that's very similar in both environments I've been in all environments that I've been in this business. I mean, that really drives it. I think differences are, the scope of complexity and the volume that we deal with in the public sector is vastly different than what I dealt with before. So in private sector and a publicly traded company and a software company, you have a set of products. And of those set of products, you have one that may be your flagship. And you put a lot of intention and focus on the one, and you're the expert. You are, in the world, the expert on this product. On the other side, I have hundreds and hundreds and hundreds of applications of which we are not an expert in, right? And we really are at this intersection of complexity of medicine, of healthcare, of academia, of technology, of particular regulations, legislation. So the pure complexity that I deal with every day is very different than what I used to deal with. I could get really specific on a particular set of challenges and feel like if I solve those challenges with my software, I'd be able to solve all the challenges that somebody in the public sector is facing. And that isn't the case. I mean, we really are dealing with a very complex system. And because of that, it's also very challenging. It's very exciting and rewarding because I think I have to think very differently every day, even from one moment to the other. The context switching is very exciting.
You mentioned in the past kind of the importance of some of the training programs that you have with technology being truly representative of the day in the life scenarios and workflows. And I think that was from an example of some work you were doing with your Expanse implementation with Meditech at Fraser. Kind of curious how you've applied that lesson since then.
We have done some level of a pivot in our end user training program since the early lessons that we learned in our Expanse deployment. And we're doing more simulation. So, one step further than day in the life, it's clinical simulations that we will run using the application prior to go live. So that's been fantastic. And we have also introduced a number of capabilities from technology perspective, one of which is a generative AI experience, which I'm proud to say, I think we're one of the first to introduce this kind of generative AI experience with our virtual AI trainer that has been trained on all of the workflow, and we call them quick reference guides, everything related to how you use the application, and you can interact with the virtual trainer right within the user interface to understand, I can't remember, how do I order that, or what is the workflow associated with transferring a patient from A to B? And you can ask it and it will give you that support. And especially now in a time where we have so many HHR challenges, it is hard to get enough super user. You won't have enough of anything. So how can we think about technology to shore up those gaps? And so being able to introduce new technology like this to help us in training and in supporting, it's really been an exciting change, and a change in what I've done before, because we didn't have this kind of technology before. So it is new for me to do that as well.
And just so I'm not misunderstanding, so it sounds like as part of training, there's almost like a training copilot that's embedded in the EHR. So if I have a question, I can go directly to the copilot and learn just right then and there to get better at using the interface. Or
right now it's running on the side, and as we further roll out the application, it'll become closer to the user interface. But we have it with the training. So as you're training, you're not in the obviously production, but while you're in the application and you're going through all of your training steps and you're understanding what you're supposed to be doing, you do have your little virtual copilot trainer there with you that you can ask questions.
Very cool. Well, since you brought up generative AI, I guess it's okay for us to talk about it. Which use cases are kind of the low-hanging fruit, most exciting ones in the next year or two for Fraser?
We're really focused on the ones that will help with the administrative burden. I think that's pretty consistent in the market. Where we are not able to meet a need, or we place so much burden on the individual that we have to think differently about it. So virtual trainer is one. We are looking at creating a discharge summary first and having our providers review that and edit versus create. That's really important. We are looking at, is there opportunities to use generative experiences to help individuals navigate our system, point them in the right direction, engage in an experience that is more concierge-like. So really anything where either it improves the experience, reduces the burden, or does something that we're just not able to do. So we're looking at, we have multiple models in our labs.
Fraser's a fairly large health system, multiple hospital facilities, lots and lots of frontline providers. As you kind of roll some of these use cases out, I'm curious what the sort of deployment strategy is. Like, do you intentionally pick, let's say, one facility or even like one department, one facility to focus on? Or how big do you start at first, and how do you decide like how quickly you roll it out to others?
We do start small. We're intentional. So intentionality on the use case, and then intentional and selective on the group of users that we begin. When we go through this process, we're asking them to test it in different ways, to interact with it in different ways, and to provide feedback both immediately and following the experience, which does require some time commitment. And so we have to make sure that we're asking those that, first of all, are willing to give us the time. That's a critical part. And that they're willing to give us the level of feedback that we need. So we are identifying key individuals who want to be part of this digital transformation, are excited about it and have the time for it, as well as there are specific sites that we're targeting. And those are the sites that are adopting technology and that want to be part of this journey early in the process. So the early adopters.
And I'm curious, have you seen an uptick of like clinicians coming to you in the past year saying, hey, like there's this new generative use case, can we try that? Like, so has engagement gotten like higher from a digital perspective from clinicians?
Yes, very interesting. I was just thinking about this over the last couple of weeks. So I've been fortunate to be here now 1 year and 3 months. I can't believe how quickly time goes. And the reach outs, what I would call cold calls, but from individuals within the health authority who have reached out and said, I have read something, I have heard something, I spoke to somebody the other day about digital transformation. I hear we're doing some really cool things. How do I get involved? And so those calls and reach outs to me and to people on my team have increased over the last, I would say, about 6 months, which is exciting. We have a lot of people who want to be at the table and who want to lead in innovative ways and have innovative ideas as well. So that's exciting. It's picking up pace for sure.
It was like maybe like a decade ago, like there were more clinicians who were, I don't want to say anti-technology, but maybe not technology enthusiasts, but it feels like a lot more folks are finally seeing the potential of it to make their lives easier. Because in the past, probably they just thought it'd make their lives harder,
Yeah.
But
yeah, these initiatives, like the Expanse rollout and others, they're always hard because they're such big clinical transformation initiatives, but the add-on effects, like this is foundational. And then upon this, we can build more capabilities and serve up different experiences to help you. It ultimately serves you. There's a different feeling and a different level of energy and more people wanting to come to the table than I would, 20 years ago when we started doing these types of initiatives. So that has changed. And of course, the virtual part, we're now layering on top of these foundational programs. We're now layering on top new hybrid care models that are providing a virtual care experience. And that has definitely people raise their hand and say, I want to understand more about this. What does that mean? How can I, practice differently? What does a care model look like? How can I get involved? That's very interesting. So it's an exciting time. I can't think of a time, and I've been at this a long time, I can't think of a time where there has been more excitement about the opportunities ahead of us and what it means to the way we work and the way we coordinate care and collaborate.
Yeah, no, that's incredibly exciting. I think it's neat. You're bombarded with vendors reaching out, but now you also have the internal stakeholders reaching out. So your inbox must just be flooded right now. I was curious, Jennifer, the Scale AI project that you're leading at Fraser Health, I believe it aims to revolutionize scheduling using AI. Are you able to delve into that project a little bit? Maybe let us know how it started and the impact that you anticipate it having on healthcare delivery?
Yes. So, it's when we look at the challenges that we're facing and we start to really drill down into what are some specific challenges that we can go after, scheduling and our HHR challenges certainly rise to the top. And so this was an opportunity that was brought forward by some partners that said, there's something here that we could really look at. There's an opportunity to think differently around demand and capacity, which, in economics, we think about that. But when we're looking at physician scheduling and the way we schedule across our acute settings, why do we schedule that way? What are the variables that drive demand and what are the variables that we have that could drive a difference in supply? And so it's an interesting question, especially if over many decades years and decades that you've been thinking about, we'll always schedule this many lines over this. Why? Because we have this many beds or this many areas. But really, what are the other variables that we need to think about? Are there variables related to not only patient acuity, but where the patient is on their trajectory? How close to, discharge will they be? The geography of the hospital and how do you move humans from one place to another? The types of tests that are planned for different people. Like, how can we start to think about demand and supply in a different way? And so that's really what's starting to drive this is, starting to change the question and really understand what are the variables. There are some studies out there that says, some of the greatest variables to understanding scheduling, for example, is more related to school schedules, school vacations, and sporting events,
Right.
So, not to say that that's what we're doing in this initiative, but we're not, but it raises the question of, okay, how do we think differently about this? And then, so we started to map it out. Again, we selected a group that wants to be at the forefront around digital transformation. We started to review what are the models that could drive and define what do we need for which days, for which shifts. And then we're starting to layer in, okay, now what is the supply side? And then how would we look at this? If we introduced a 4-hour shift here, for example, would that alleviate, and in what way would we see an outcome? Would we see better throughput? Would we see increased access? So it's starting to look at it in a different way. And it's very exciting that we can do this with different models and start to flex the variables.
Another neat part of the project that maybe wasn't anticipated from the get-go is just this idea of you now get this bird's eye view, kind of high level view of what's going on across the entire spectrum of this scheduling operation. So like you were saying before it was just looking at number of beds, but now it's so like nuanced and understanding all the elements that go into throughput with patients. It's really, really fascinating to me.
Yeah. And to be able to ask like the what if scenarios, well, what if we did this then what? And what if we did this then
Right.
what? Model that out before we would ever take any action at physical realm. That's very exciting.
Yeah. Can I ask you, would this ultimately still be more of like a copilot scenario where like the solution may recommend this is the way that we should staff situation, but it doesn't force it? Someone still has to kind of sign off on that?
Yes. For now, the vision is that it gives a set of recommendations and then we can decide to take action on those. And if we do, then we measure the outcome. Does that align to what the model suggested? So that's where it is right now.
Pretty cool.
That's pretty cool. Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that That is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more. Just a step back for a minute, Jennifer. You mentioned, obviously, this Meditech Expanse implementation. I was really curious, just given your background, you've implemented EHR systems all over the place, tons of health systems in your career. And so I was wondering, when you were part of the Expanse implementation, were there any unforeseen challenges or anything that was new for you?
I think what may have been new or slightly surprising, although I've been doing this a long time and there aren't a lot of surprises along the way, but one of them was it's still hard. It's still a really hard initiative. It's a resource intensive. We're asking a tremendous amount of our clinicians, our providers, in a time where they don't have a lot to give. And so I think there isn't, if I were to compare the way we are doing this today versus the way I've done it over my career of 20 years, I would say it's not really that different. It's still hard. It's still a big project. But I think where things have changed is that EHRs now, they're table stakes, they're required, they're absolutely critical, but they're foundational and they're not our strategy. 20 years ago, when you'd sit with organizations and they'd say, our strategy is to implement, our IT strategy is to implement this EHR. That is the strategy. It's different now. This is a foundation upon which we transform with other things and additional capabilities, additional experiences, composite apps, etc. And so it's a different conversation. It's the beginning of the journey. It's not an end state, but it's still hard. And I think something's happened over the last few years where we've kind of taken our foot off the gas as far as what clinical transformation looks like. And we've had to really refocus that. This is a clinical transformation initiative.
When we talk about the emergence of digital front doors, I think one of the neat things about Fraser Health is that you have the cutest and the best name for a digital front door in Fraser. So you might tell us a bit more about maybe the genesis around launching your digital front door and any kind of key learnings so far?
Yeah, that has been a really fun project. So it's been the vision for us that we have a digital entry point that provides a relationship. It establishes a relationship. It has a level of personalization. Because of that, we know you. We know what you need. I mean, really, that's the vision of how we can embrace those we serve. We serve 2 million people, and we think about those 2 million people every moment. How can we establish an entryway and then help you navigate the system? Because we're a big system. We have a lot of services, a lot of facilities, services, and operations. So how can we help you navigate us? And so we were building out what this experience would look like and what the interaction level would be. And we wanted to start with a chatbot type experience that would help walk you through. And it was an evolution of what does this bot look like. And it was very obvious that, we wanted it, we didn't want it to be gender specific. We didn't want it to be, we really wanted it to be a Fraser focused experience. This is who we are. We're projecting who we are and how we care, because the Fraser heart is real. So how do we put our heart out there and embrace those we serve? And it led to an obvious avatar of a little Fraser. And it's a pretty cute little dude, to say. And we're mapping out Fraser's life journey, because Fraser will continue to grow and and it will start to become generative in the future. It will have more and more capabilities and be able to target more and more interactions and experiences as it grows. But it's very early days with Fraser, but we're excited about what we can do with it.
Awesome. Can I ask you how you decided what the initial set of services would be for Fraser and Digital Front Door? Because I can imagine there's a laundry list of services you'd want to connect into the front door, but you can't do it all on day one. So how did you decide, like, what are the low-hanging fruit pieces that just have to be there at launch?
So really, it's around one of our key pillars in our digital health strategy is around timely access to convenient care. And that word is intentional and it means a lot. So it was about access and it was about convenience. And then we looked at what are the types of services that are Googled most frequently, or do people search for most frequently? And so those were the services that were first identified. And this is really being driven from our community and population health areas. So that team is involved in the advisory group and is really defining this. So it was from a need perspective and from a reach into the community. It's very much community side driven.
Let me ask you, like, were folks actually like looking at, I don't know, like Google search analytics and keyword trends, trying to figure out, okay, like, what are patients in our like region like searching for? Like, did that sort of analysis happen? I was just kind of curious if that was a piece of it.
We get a lot of questions through different mechanisms, so it wasn't difficult to see what kind of questions we're getting. We do have sentiment, so we can see what people are talking about with us. So we do have a dashboard around that to see what's being asked in the public domains, which Google would be one of those. And then what's brought up, we have our public board meetings and the types of questions we get, it's very clear to us that we need to expand and provide navigation and availability of certain services. And so a lot of them are around our mental health and substance use services. And so that's really took a focus in the development of the little Fraser.
Amazing.
Yeah.
Fascinating. I'm going to just switch topics a little bit. 5 to 6 years ago, you gave a really brilliant TEDx talk around the notion, and I love that you're smiling at it, nice does not equal kind, and you advocated for kindness over agreeability. I'm curious how that philosophy has played a role in your leadership style today, and maybe your efforts to foster a culture of really authentic leadership and empowerment, especially among women in the workplace.
Yes. So I think part of that is also, it's agreeability and it's also passivity and it's finding your voice. And so I'm very passionate about women progressing on their growth trajectory as far as their professional goals and aspirations, and ensuring that all of us can achieve our greatest potential and achieve our dreams. And so working with women over the years, I've been involved in a number of different groups, and that TED Talk was sort of a summation of my own trajectory where I found my voice. And I really think about how I can be very clear in my communication, and that I coach and mentor other women professionals to do the same. Sometimes it's easier to stay quiet and not either share your opinion or speak your mind, and put your thoughts on the table. And so because of that, then there's a level of agreeability, and that really isn't the right way for women leaders. You want to be able to share your opinion. Your opinion is valued. You're here for a reason, and be able to speak up and share that has been really important. And I had to learn that, because I don't know if it's part of the demographic that I'm in, but when you're raised, and part of that, the title of that talk is intentional, because when we're raised as little girls, often you're told, don't speak unless spoken to, be quiet. And so I think that was something I really had to identify early as a professional. And so I do work with other women professionals to speak up, straight talk, listen well, share your opinion, and put your ideas on the table. I want to get.
Yeah, I love that. Do you mind to just quickly unpack? Because I think I know what you mean, but the phrase like nice does not necessarily mean kind. How would you kind of unpack that a bit more?
So I think it's important. I mean, we're always need to be kind in our interaction. And I think kind is a leadership superpower, to be able to demonstrate kindness, to take away and to remove where you think about judgment and replace that with curiosity and understanding and bring forth empathy. That's all part of being kind, being a kind human, and being a kind leader, and understanding your team, understanding when we have some challenging situations, which we inevitably will because we're human and we're in healthcare, and healthcare is all about relationships. So I think you always need to be kind, but there's a difference between that and being nice. In other words, stepping back from a difficult situation, not having the conversation that needs to be had, leaning away from potential conflict. And I don't think conflict is bad if it's done in a way that leads to a productive end and to an understanding. Guarding and or not sharing your great ideas, that's a problem, because we have so many challenges, especially in healthcare and technology today, that you have a seat for a reason, and we need to hear your voice. Mm-hmm. So you're asked to do something and you simply go and do it, even though you know it's not the right thing to do, because the process doesn't make sense. The technology isn't there. It's not a feasible option. But to be nice and to go off, I'll go do it. That isn't really what we need to be doing. I need to understand if it's not a feasible option. I need to hear from you it's not a feasible option and why. Good. And then let's move to what is the solution, because there are plenty of challenges. So does that help?
It does. And it kind of reminds me, I think, of the idea that often the kind thing to do is to tell someone the truth, even if it may hurt their feelings. Because the nice thing to do would be to not tell someone because you don't want to hurt their feelings, but it wouldn't necessarily be the kindest thing to do, to withhold that opinion from them. So that it reminds me of that makes a lot of sense. It takes a lot of courage to be fully kind, I guess. It's not easy.
Bravery and courage, also really important leadership characteristics for authenticity.
Yeah, totally. Just kind of expanding on this idea, there are still circumstances where you may be the only woman in the room presenting to all male executives in healthcare. And so I'm curious, what advice would you give to women leaders out there who might be facing that kind of similar situation?
Less so now. I will say I am so fortunate. I have a woman CEO and a great group of women executives that sit at the table with me every day and every week. So it is wonderful. However, I recognize in other settings that still persists. I think when I gave that talk, I think Forbes said there were less than 5% of the Fortune 500 companies had women CEOs, and now we're at 10%. So I think, we've doubled that I can't remember I think 6 years ago. So in 6 years, we've doubled that. Fantastic. But 10% is a long way from 50%. So yes, that is certainly happening, where we have women professionals who are on their own at a table. And so one thing I have said is you need to get your ideas on the table, and you need to persist in how you want to position either your innovations, your awesome solutions to some of these problems, and make sure that you interject and you get heard. I think that would be my greatest advice to women who are sitting at the table on their own with a group of men. And, they'll historically help one another and hear each other. And sometimes you need to be a bit louder to be heard.
Yeah. So Jennifer, just being mindful of your time, let's flip over to the Fast 5 lightning round. So this is just 5 rapid fire questions for you. The first question we have is, what is your favorite book or book you've gifted the most?
The Martian. Andy Weir's The Martian. And I've watched the movie probably 10 times.
I love it.
I've only watched it once, but it's a great movie. Yeah. I need to watch that again.
Question 2, who is a person, either dead or alive, you'd love to meet?
Probably Rosalind Franklin, the lady of DNA.
Nice. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
I'd like to go for a different option and say I would like to be able to pause or control time and time travel. I think time is our most precious gift. If I had any superpower, it'd be related to time.
I love that.
Wait, can I ask a follow-up question? Let's say you could only time travel to the future or the past. What power is more interesting to you? You can travel back to the current times. You can always do that, but you can only go forward or backward in general.
Yeah. So I always like to think forward. I always think up and to the right.
Good.
So I would say I'd want to go forward.
Nice.
The total unknown.
Yeah.
Yeah. Yeah.
Amazing. Question 4, what is something in healthcare you believe that others might find insane?
I think others would find it insane, the costs of healthcare. And for example, an ED visit costs us $400 or $500. And I think that is insane.
Yeah, totally agree. Last question that we have, if you could travel back in time to any event or moment, what would it be and why?
Well, I am a scientist at heart. So again, I think I would want to go back early days when we were learning about genetics, the helix, and be able to work with those who are sitting at a bench using different type of x-rays and capabilities to better understand what a DNA molecule is. I find that very fascinating. So
Yeah.
I think that would be where I want to go.
Definitely. That's
What's
awesome.
cool. No one's ever said that before.
I know. Yeah,
Yeah.
That's the first time we've heard that. Also, your superpower pick to choose a fourth option. I know we have had a few guests who have done that, and I think I did that myself when we did it to each other, but I love all of those answers. So refreshing, really awesome to hear. Well, that's a wrap on this episode, Jennifer. Thank you so much for spending some time with us and sharing some wisdom with our audience. If you like the podcast, you want to learn more, visit www.siemens.md. Jennifer, Mr. MacGregor, again, thank you so much.
Thank you.